please.
Ça marche,
Oui,
c'est en
je vais
mec.
regarder.
Ok. C'est un gentil mec que normalement travaille bien.
Oh, vous parlez français? Ah, really? Ah. En fait, c'est juste que sur un Mac, il faut que j'adapte la fréquence d'affichage de l'écran
Ok.
sur la machine. Mais ça marche pas à tous les coups. Où est-ce que vous avez mis les préférences?
Est-ce que je dois changer?
Non, vous n'avez rien à
non.
faire.
Ok. Après.
C'est moi qui dois me. Non, 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 non.
Ok.
Ah. Ça doit être ça, je pense.
Ok.
Mais ça ne marchait pas. Pour nous, hein, pour vous, ça ne change rien au niveau de l'affichage. Après, quand vous allez aller dans une autre salle, il va trouver l'autre écran, il va trouver un autre nom et le Mac le fait tout seul. Mais ici, on a plusieurs possibilités. Donc en 60, ça ne marche pas.
D'accord.
Ne bougez pas dessus.
Fertig? Je peux finir? Marche? Pas?
C'est qu'il reconnaît l'installation, mais pour vous, c'est bon. Je pense qu'on revient au PowerPoint.
Et je peux mettre...
Ah, vous avez besoin de la clé? C'est pour
seulement pour les
no
pointures.
problem.
Ça marche?
Oui.
Je fais.
Je vous le mets en... Ah, c'est un PowerPoint. Je ne sais plus comment on fait. Je vous laisse faire en fait.
Essayer.
Il faut revenir en affichage.
Un instant. Est-ce que je peux finir?
Oui. Allez-y.
It is. They were on the chart. Like
No, they were not.
when they came.
Yeah, I put them. Exactly at what time? Exactly having one of them.
Ils viennent peut-être.
Avec des balances à la
Ouais.
There's a concept hole.
Est-ce que ça vous ennuie de faire une diffusion sans faire le double écran?
Le double. Alors, j'ai aussi les présentations sur 7.
Ah,
Peut-être on peut essayer avec
sur un
votre...
PC? On pourrait essayer
Sur
en ligne sur un
votre-
PC?
Votre PC, moi je
you try
dois
and,
faire l'échec avec les vidéos. Je ne sais pas que les vidéos fonctionnent.
You
Parce
understand?
que c'est essentiel que ma vidéo fonctionne.
Okay, let's check if the video works on your computer.
Si ça marche, ce sera peut-être plus efficace.
Oui,
Parce que sinon,
parce que c'est
ce que
plus
j'allais
facile.
proposer, c'était faire une projection, mais comment dire, sans utiliser le double écran.
Non, non.
Non, ça ne vous plaît pas, parce que vous avez vos commentaires qui sont dessus.
Parce que j'ai ma commande sur mon tel.
Je comprends.
Oui. Ok. Et aujourd'hui, quand je parle, seulement 10 minutes, ça marche. Mais quand je parle 1 heure...
Oui, il faut avoir un peu de contenu.
Oui.
C'est normal.
I'm assuming Lyon.
Yeah.
Okay. We can run it from there, or we can just presentation.
Attendez un instant, on va voir quand ça fonctionne avec 7.
Est-ce que je peux
Yes.
prendre le... Oui.
Ah, yeah. les vidéos dans les présentations. Normalement, ça fonctionne, mais ça dépend toujours sur la sécurité.
Okay.
Now,
To say that.
Okay.
Can
Yes, yes. So much. Ah. No.
marche pas.
Ça c'est probablement parce que il faut que le média soit sur la clé.
Aussi.
Aussi.
J'ai aussi dans les présentations, attends. Wait. Ça
charge.
charge. C'est parce que normalement,
Le
ça
média,
fonctionne.
parce que le média, il doit être sur la même,
Oui, la même.
le même, comment dire, le même dossier.
Oui, parce que je connais les problèmes chaque fois avec les mecs.
Ça doit fonctionner.
Je dois
Clic, ouais.
un clic. Attendez.
Ok.
Ah, ce sont plus vidéo. Ils vont faire l'échec.
Il y a de l'audio. Il y a audio.
Non, audio non.
Alors, moi, je vais avoir besoin de...
Attendez. Ok. Maintenant, les autres vidéos. Ce sont aussi des...
Okay, kannst du drehen und wieder zurückdrehen und wieder hindrehen und wieder.
Okay. Okay. Klick. C'est la même.
Ich weiß aber nicht mehr, welche Zeit.
Ja, wahrscheinlich eher 10:30 Uhr. Ah, echt? Gut, ich glaube schon 10:30 Uhr. Ich hab's nicht mehr. Cool, ne? Aber es war, glaube ich, Vormittag.
change the frequency of
We can check. I never changed it. But is it default 60 hertz?
This for me.
Yes. What did you do? How did it start?
So we have to activate because normally because I know this issue, I load my presentation and my videos into the presentation to be independent of,
Yes.
and it worked.
The
But
file
it
is-
needed to be loaded up in the presentation to be activated by click.
Okay.
So then you can plug me out there.
Yes.
I need not this.
Another way is to make a GIF out of the video.
Yeah.
GIFs work like pictures,
Okay.
but you need to make GIFs out of every
Yeah.
video. So I just load everything in, and it's like 1 gigabyte, but
Okay.
it's
Yeah. It's fine.
settings are here. Ok. Pourquoi j'ai pas les settings?
Frequency? No. Screen.
Screen, yes. Yes.
Here it's.
Duplicate. keep the display setting.
System
Keep
advanced.
change.
Ah, advanced.
Ok. Là, on va revenir à... Non, c'est pas ça. Your presentation is this
mine.
one. Ok. C'est là, c'est pas là, je sais plus si c'est là. Where is the full screen?
Here it's a full screen.
Okay.
Yep. Perfect.
Wait.
Okay.
You need to confirm there, and then it's
Okay.
perfect.
And I can use this now? If I
Yes.
can use it.
And there is a laser pointer here if you want.
On the top, huh? This is the laser pointer.
Sorry? Yes.
Pointer.
It's yes, right.
Let's see how I can activate. Can I click through? Yes? Just to see how I activate the videos. I go the way back. Let me see. Then I'm faster to the videos.
Ich weiß aber nicht mehr, welche Zeit.
Ja, wahrscheinlich ja. 10 oder
It's again the tone. Can you mute it, please? I don't. I need no.
Yeah.
Not at all. So, because even if you start it again, that's what I told you before.
Yeah.
It activates again.
It's very strange.
It's strange, huh?
Hopefully.
Let's go back.
Okay, no tone.
And the other one. Yeah. Okay. It's by clicking. Okay, that's fine.
Okay to start in like 2-3 minutes. Okay, I'll start.
It's fine. I'm not in a hurry.
Est-ce que vous allez faire votre présentation assise ou debout?
Encore une fois?
Est-ce que vous allez faire la présentation assise ou debout?
Non, je marche.
Ok, il vous faut du coup un micro.
Oui, moi, je me dis que ça ne fonctionne pas parce que les batteries pas chargées. Pas chargées. Alors
Le
je
problème,
suis.
c'est que si vous bougez, moi je vous entendrai pas. Enfin, ça partira pas dans le streaming.
Alors je reste un peu.
C'est celui-là.
On va faire comme ça.
Celui-là fonctionne pas.
Ah, ok. Oui, ça marche.
Et dernière recommandation.
Oui.
Le speaker précédent utilisait une LED pour montrer sur le diapo. Et ça, c'est moins bien que comme ça.
C'est pour 7, j'ai 7.
Ouais. Pour changer les diapos, mais pour montrer quelque chose
Oui.
en...
C'est mieux que je faire comme
Voilà,
ça.
exactement.
Ok, d'accord. Seulement.
Mais sur l'autre, alors du coup, je pense que c'est là, voilà, ici.
Ok.
Ok.
Et où?
Vous pouvez la voir que là-bas.
Ok. Oui.
Ok.
Ok.
Parce que sinon, ça, moi, je ne peux pas le filmer.
Oui, parce que c'est pas transmis. Ok.
Merci
J'ai
beaucoup.
compris. you already instructed me
okay.
how to behave, how to move.
Don't move.
Don't
Breathe.
don't move, don't breathe.
Exactly.
Stay still.
I'll have to talk here as well.
Okay,
I'll just literally say 2 words just to introduce you.
perfect.
Okay.
Go ahead.
I saw roughly your presentation, so I don't want to step on the presentation. Just say who you are,
That's fine.
as if they did not know. Yeah.
Fine. Feel free. I will react what you
Okay.
told. Feel free.
Okay, everyone, we are starting. Hello. Okay, cool. So now presenting is Dr. Ines Birch. So Ines is a physiotherapist who did a PhD on upper and lower motor lesions in tetraplegia. Right? And she is the head of the international FES center, which is part of the Swiss Paraplegic Center. So you can begin.
So thanks for the introduction. I don't want to talk all the time like this, so hopefully you can understand me. I will arrange it. I was told not to move a lot because only this microphone will work. So I'm a mover normally, but okay, I will stay still here. So it's very difficult, Emilia. You are absolutely right, but I will handle it. So I want to take you the next 40 minutes onto a journey of our research projects, and we are dedicating, of course, electrical stimulation, this fantastic tool, and we use it for diagnostics, prognostics, and treatment in the upper limbs of tetraplegia. And so we will start. The International FES Center, and I feel very privileged, can work with patients, patient treatments, and we have also the possibility to do research. We do it 50/50, and the results of our research are not only applied on our patients in form of novel or changed treatments or modified treatments, also in education. And we give courses on regular basis, or I'm teaching at the universities to implement our new knowledge so that we can spread what we all have investigated in our research. And that is the way it should be, because unfortunately, on the level of therapists, each PTs and OTs, electrical stimulation is sometimes a little bit underestimated method, and I want to bring it more into the community. So researchers are very well on this, but therapists have to improve a little. And I'm allowed to say so. Okay. So in the next 40 minutes, I will dedicate on life priorities of spinal cord injuries. That brings us to our research focus. I go briefly into the principles of electrical stimulation because we are dealing with 2 types of lesions, upper and lower motor neuron lesion. And I will give the physiological background in the upper limbs of it. And then I go to a diagnostic method that we developed, that's the motor pond mapping, and how we transferred it to a prediction model, how we can use it for treatment to predict how to treat the upper limb of a tetraplegic person, and what kind of treatment should be useful, and a little bit to get rid of the standardized treatment that is announced everywhere. And also to tell you our treatment strategies. Okay. So life priorities in persons with tetraplegia. So you see these nice little pictures. We will dedicate on hand and arm function tetraplegia, and that's indeed a life priority after spinal cord injury in tetraplegics. and paraplegics, we have also bladder and bowel function, and we have skin integrity. These are also our three, in the FEST Center, our three main research topics we are dedicating. And today I'm talking about the hand and arm function in tetraplegia. So here you see it statistically. When you look into surveys, you see that hand function, and you see in tetraplegia. No, wait, I have to do it on this. You see here, you have hand and arm function that has a really high impact for tetraplegics. You can see it on this slide here, the high, the high impact, and you can see it on this, the high priority of tetraplegic person. And of course, when we are talking about paraplegics, walking has another priority. But only by looking to tetraplegics, hand function is quite crucial. Okay, electrical stimulation. The principles are crystal clear for everybody, but nevertheless, I want to shortly focus. You do a transmission via nerve or via muscle, and you are creating an electrical field, very simply, under the electrodes. And I think one important point is, depending on your parameters, you are either have the depolarization of the cell membrane of the neuron, or you elicit a muscle fiber directly by increasing the action potentials. And that is, in the upper limbs, essential for choosing the right parameters in lower motor neuron lesions. Okay, the results that you have a muscle contraction at least, and the chemical procedure, electrical chemical reactions that take place, they are very similar to physiological processes. Okay, so it looks like, and I think that is one of, I want to centralize here. You have this nerve stimulation, and you have the muscle stimulation. And by looking to the parameters, we are talking, in case of nerve stimulation, we are talking, when we are talking about pulse duration, we are in the microsecond area. And if you are using muscle stimulation, and some of you are also very keen on muscle stimulation and on denervated ones, so then you are talking about milliseconds. And that makes a huge difference in the application of electrical stimulation. Therefore, we have to know anatomically where is what. And so the anterior horn is a crucial point. There you have a change point where the upper to the lower motor neuron lesion is changing. And so we have in tetraplegics, and I will come later on it, you have in each tetraplegic person, you have an upper and lower motor neuron lesion in the upper limbs. Below the level, you have no problem, you have this upper motor neuron lesion, but crucially on the level of lesion, we deal with a mixture of different lesions. And that makes sometimes stimulating the upper limbs not so easy. Good, the differences in parameters in clinical practice are written on this slide. And there you can see the pulse duration in an upper motor neuron lesion is normally in a range of 250 and 600 microseconds, in contrast to the lower motor neuron lesion, where the pulse duration is about 35 or even 10 milliseconds to 200 milliseconds. So there are differences. Also, the frequency is different. The frequency in an upper motor neuron lesion is about 20 to 50 hertz, and lower ones, we are dealing below 1 hertz up to 22 hertz. Of course, you can create current up to 30 hertz, but then the application gets quite challenging not to burn or irritate the skin, even if you use correct electrodes. So you have a little bit aware of it. Waveforms are mostly similar in lower motor neuron lesions, I like to play with different waveforms just to distribute the electrical field differently and to reduce the aspect of uncomfortable sensation. Good, a spinal cord injury, you know it. I don't want to talk about it, but here we have also the issue of, and I say it a little bit more simple now, we have this incomplete and the complete ones we are dealing with. And of course, you have the Asia classification where you say A, B, C, D, but motor complete, motor incomplete, and sensory complete and incomplete are for me in this talk the most important two edge points that we should deal with. Good. So, and you see already on the right side of the slide, you see this symptom, and it's no doubt that this person has a tetraplegia, and we see it quite often like this. And now we are looking a little bit into the detail. And I talked about upper and lower motor neuron lesion, and here we are exactly. In the field of lesion, you normally have a damage of the anterior horn cells. And so in this region, bless you, Isan, and in this region, you have a denervation or a lower motor neuron lesion on this segmental level. If you look one level below and one level above, there are almost partially denervated muscles segmentally. That means those muscles you can't excite via nerve if you use electrical stimulation in a proper way. You have to use direct muscle stimulation. So, and if you go more segments below, in case of tetraplegia, then you have, of course, muscles innervated by an infralesional segments, and you have an upper motor neuron lesion. It's easily to elicit a stimulation via nerve. But here, this area is very critical in the upper limbs. And if you look now to the schedule, it gets even more interesting because you see that the segmental innervation of the upper limbs is not concentrated on one segment. There are almost more segments. And that means that the partial denervation is even more spread out. So therefore, testing upper limbs before stimulating to get an effective stimulation is important, because otherwise you are treating upper limb muscles that are partially denervated with electrical stimulation, nerve stimulation, and you get somehow a response, but no improvement, because you have two less parts that have an upper motor neuron lesion. And those who have a lower motor neuron lesion, those fibers are lying back and letting the current pass by. Okay, here we have the muscles I want to dedicate on, that are the extensors of the hands, the flexors, and also the thumb muscles I want a little bit to concentrate on. Okay, so therefore you can use electrical stimulation as a diagnostic tool to identify where a lower motor neuron integrity is missing. And by having this knowledge, what kind of muscles is somehow innervated, not innervated, or even voluntarily innervated, you can have a prognostic in combination by the knowledge of the INSCI status or the Asia status of the individual. And then you can create at least a treatment very individualized and specialized for each individual. Okay, let's come to the motor points. So motor points you know from a physiological point, but in the upper limbs, a motor point can be defined a little bit differently, because if you put electrodes on the forearm, you have so many muscles beside, below, above, down. And if you put an electrode on, you get a response of everything. To find out the excitability of one single muscle, you have to look where you can create an electrical field where you exactly reach only this muscle you want to test. And yes, it is possible to do so. And I will show you for the most crucial muscles. And we decided to identify those muscles that can be used at least also for reconstructive hand surgery in terms of tendon and nerve transfers that are important also on this level, but also important for treatment of the hand without surgical interventions. And you see on this graph here that I already differentiate between the motor point and the sensory nerve point. And I'm now talking about the motor point. That is for us important to identify the selectivity of a single forearm muscle. Okay, how do we do it? Very simply. We use a stimulator, nerve stimulator, and a pen electrode, and we apply a nerve stimulation with 35 hertz, with 300 microseconds, and an amplitude in between 20 to 100 milliamps. And it's depending on the muscle size. And the intensity, of course, tells us also something about the excitability of a muscle. And then we use this testing and transfer the classification of the electrostimulated muscles to the British Medical Research Council scale. So we say, okay, we deal with an innervated muscle, but not necessarily voluntary innervated, can be an upper motor neuron lesion. We say, okay, if this muscle shows us a movement from a muscle test value from 3 up, that means full range of motion against gravity, then we have of sure an upper motor neuron lesion or an innervated muscle. If we see, bless you, if we see here a reaction that you see only a slight contraction or slight movement at the same motor point, then we can estimate that this muscle is partially de-innervated or innervated, depending if your glass of water is half empty or half full. So we don't know the percentage of de-innervation or innervation, but we know, okay, there is some de-innervation in. And if you see no contraction via nerve stimulation, then you are dealing with a lower motor neuron lesion. Okay, so again, if I'm talking about now innervated muscle, that does not necessarily mean voluntary innervated. And so signs of de-innervation in a muscle is not necessarily accompanied with no voluntary activation. So that means you can have a voluntary active muscle that also has parts of de-innervation in, or lower motor neuron lesion. And I think that makes this field so amazing. Good. Here are our motor points that we defined on the forearm, and you see the several muscles here, and this system can be applied on each forearm because the points are independent of the forearm length, and they are defined. You can calculate them. It's easy to do, and of course you need something to measure. You need a pen, and then you put your crosses on the forearm, and you can go on stimulating those points. And you have for the palmar and for the dorsal aspect of the forearm. Okay, how does it look like? And hopefully it will work. Just a shortcut. You see the equipment here. Again, bless you. And you get a quite nice movement, what you want. And you see it also for here, in this case, for the pronator muscles, turning around the forearm. and also for the FDP, for the deep finger flexors, tested by the middle finger, and for the thumb also. Okay, so by testing some, or not some, a lot of patients, and this is only a few are picked out of our database, if you look to them on the dorsal aspect, there's one interesting observation, and I will do it like this. And we are only looking now to the extensor digitorum communis, for the finger extensors. You see, and look only to the colors. You see this dark blue, and dark blue means denervated. Light blue means innervated, and this somehow middle blue, only one of those, is partially denervated. And you see that in those patients, and they are from C5, C4, C3, all the tetraplegics we collected, they have either a denervation sign in the extensors or an innervation sign. No partially ones. So now, change around. Let's go to the flexors. And then we do the same with the flexors. You see, if you look to, don't look to the pronator, to the PT left and right. Look only to the FDP muscles on the right and the left side. And only by looking to the colors, you see that the flexor muscles have more partially denervated ones. So there are more mixtures in. And why is it important? Because if we skip now electrical stimulation and look to the outcome that is described for reconstructive nerve surgery, then we know that the outcome of the flexors by having a nerve transfer is less promising than for the extensors. And a nerve transfer is only performed if the target muscle that should be reanimated has an upper motor neuron lesion or is innervated and never denervated. And if a muscle is partially denervated, that might be in what is the case in the flexors. That might be a reason why some reanimation of flexor muscles is less successful, because they have more problems. And there's another aspect I want to show you. If we look to the segmental innervation, we would never expect, and that you can't test by the Asia classification, you would never expect muscles denervated, or the FDP denervated, in a C3 Asia A lesion, because this is not the segmental innervation, not even one level above. So be aware of denervation signs out of the scope of segmental innervation. And that's also important, not only by looking to surgery, it's also important that we perhaps expect spastic muscles above the level of lesion that we never would do as therapists. Okay, so motor point mapping, we exceeded, of course, to the lumbricals, because they are also important, and you can test them nicely. You see it here by putting this electrode on. We applied also on the upper arm for delta, triceps, and biceps, and brachioradialis and brachialis. But we are concentrating on the hand now. So now we switch to a tetraplegic hand. Tetraplegic hand. So the standardized treatment is tenodesis grasp. But is a tenodesis grasp the one and only? And for everybody? And perhaps some of you already made the experience. You try to get a nice tenodesis grasp for each tetraplegic person. And you are taping, you are splinting, you are positioning, and at the end, you have no tenodesis grasp because the hand develops somehow. And we should have a little bit a deeper look why this is the case. This is a nice tenodesis grasp, and it's in practice, and I can say so. since my 30 years experience in spinal cord injury, you see them really seldom, this classical ones you want to have as a therapist. You see different forms of hands. And with the tenodesis grasp, you all know what you can do. That's nicely, but we have to find other strategies to bring a good hand function back, because this is seldomly achieved. Good, what did we do? I talked about the big database we had, or we have. So, and we looked for a prediction model. How can we say, do we expect a tenodesis grasp, or what kind of shape of the hand can we expect? And we looked to 288 upper limbs. That means 144 patients. And we did this motor point mapping I explained previously, 2 weeks, 6 weeks, and 8 to 12 weeks after spinal cord injury. And we had this manual muscle test, the MRC, and we had also the classifications, the neurological one. We did the same for some muscles, a database of 82 patients, 159 hands, and we analyzed them 2 months post-injury, and we looked to the extensor, to the abductor, and to the long flexor of the thumb. Okay, and on this little figure here, you see already the distribution, and you see that most of them are located in the cervical C4-5 region, and there you see that incomplete ones, D and C, are really a high number. If you look here to the flexor and extensor, you see it's very busy, but only look. That's amazing. My colors got lost on this computer. I had normally more colors in on my Mac. So I'm sorry that I didn't check. I lost my colors. That's tragic in this slide. I can tell you. That's not good. But however, you can see that in those who are, I explain it to you because I know how are the colors and what does mean, okay? That in the incomplete ones, Asia C and D, you have more partially deinnervated muscles and more innervated muscles than deinnervated ones. Okay, let's go. And then we had a look, and that's a little busy, this slide, I will explain you. We looked, okay, if we do a motor point mapping 4 to 6 weeks, and we have there the message, do we have a innervated, partially deinnervated, or completely deinnervated muscle in regard of extensors and flexors? And we have this A, B, C, or D. Then we can see after 24 weeks, we can estimate the voluntary muscle activity. And that's crucial. That means if I have in the beginning a deinnervated muscle, but some voluntary activity, and I am Asia D, then I can expect after 24 weeks that this muscle force will increase. If I have an innervated one with no muscle activity at all, but an intact reflex arc on this muscle, I can be calm because then I will get somehow voluntary muscle activity after 24 weeks. And so we looked, how can we apply really treatment or splinting or passive mobilization or FES on those muscles specifically, and not only putting them tape around the hand expecting a tenodesis grasp. Good. So far, so good. And if we look to those possibilities, we can identify, only by looking to the EDC extensor and the flexor, we can identify 4 different shapes. We have this open hand, we have this somehow open-closed hand, and we have the nice tenodesis grasp that really develops quickly. And we have this number 4, this claw hand, that is not really of functional use. People arrange with it, but that's not what therapists like to have. They try to avoid this, to give more functionality to a person. Okay, what is in terms of motor point mapping behind those 4 scenarios? The same with the thumb. You see thumb position, you see a nice pinch thumb that can be used. You see this nice position, but with somehow a space in between the index finger and the thumb. That's a so-called slack thumb. It's not useful for function because it's slacking around. And you have the thumb and palm that you never want to have because that is really disturbing by using your hand. Good. And here you already see what is behind. If you look to the motor points, in the pinch thumb position, you have statistically significant found that the motor point of all those tested muscles are intact, so innervated, and you have at least a manual muscle value from MRC1 on those muscles. Then you receive quite good result of those. In the slack thumb, you have no voluntary muscle activity on the mentioned muscle, and you have a denervation sign on it. Thumb and palm, there you find a mixture of denervation, of partially innervation, and of innervation mainly of the long flexor muscles that makes the thumb into the palm at least. Okay, getting back to the hand. So if you have this open hand, both muscles are tested deinnervated. So you have on both, on the flexors and the extensors, you have a lower motor neuron lesion. And you can tape them for the rest of the life. You will never get a tenodesis grasp. You can get contractures if you tape them, but not a tenodesis grasp. So then you have both muscles innervated with an intact lower motor neuron. Then you find somehow a good functional hand that can be used really good, but it's not typical a tenodesis grasp. Then you have the FTP innervated and the deinnervated EDC. That's the nice tenodesis grasp. And then you have the other way around. The EDC is innervated and the FTP deinnervated. And there you find this claw hand. So this is a hand to be really early identified to do something to avoid this claw hand. Claw hands produce contractures. Good. So now we come to the treatment. So to close the loop from diagnostic to prognostic to the treatment. So we recommend by having this knowledge in the first scenario, so it's very questionable that a tenodesis grasp will ever develop. So the risk of developing contractures are there. It's highly there. So we recommend to evaluate an early nerve transfer in a really good time manner because nerve transfers are time sensitive. And by waiting to it, we highly recommend to stimulate those deinnervated muscles to maintain the contractile muscle tissue that in case of a nerve transfer, if the nerve branch wants to grow in this muscle, that the muscle has a structure that can take activity over. So, of course, splinting, if I tell therapists forget splinting, they will kill me. So I will never recommend not to splint, but do it in a way that you change splinting. Never leave splints overnight or more than 2 hours without taking away, moving the hand and bring in another position. Scenario 2. Okay, that's nice. You can, if possible, train the people for somehow possible tenodesis grasp. So it is considered to be aware of tone disbalance. So if here you are very often dealing with spasticity on one or the other side, but here electrical stimulation is really a gift to have. You can do nerve stimulation in functional tasks. You can use EMG-triggered stimulation and implement it into daily treatment activities, not apart, not beside. No, include it, use it. And of course, splinting is not necessary in those hands. Why? They can use their hands immediately. And you can evaluate, of course, possible reconstructive procedures in terms of tendon transfers to make it even better, those hands, if you want, but it's not necessarily. Good. Let's go to the third scenario, the classical tenodesis grasp. So, yes, tenodesis grasp needs passive mobilization, because if the hand is all the day in this position, and if it should be used in a proper way, then the articulation has to be good. The mobilization is recommended and needed for those to avoid contractures. Perhaps you can splint, but yes, but I don't recommend, because this tenodesis grasp will develop if you splint or not. And I would recommend also nerve transfers to evaluate if the person is ready to do so, because then you can do some nice hand opening and using the hand with voluntary activity. So that's a nice way. Scenario 4, we will never receive or get a tenodesis grasp. So evaluation of reconstructive procedures of the denervated muscles is really important to maintain the mobility of the MCP and the proximal joints. And these hands are crucial for developing intrinsic tightness. And intrinsic tightness avoids, at least if you have the possibility with a nerve transfer to flex your fingers, that you can't close your hands in a proper way. Because what we do by flexion the fingers is that we make this. If the intrinsics are too tight, then you do this. You can't close your hand. Intrinsics are responsible for the flexion of the MPC joints, to have this whole curve and closure of the hand. So that should be a little bit taken into account. And taping of the fingers is really not recommended, because if you put an external stimulus onto the extensor side, and I will come later on it, then you excite those muscles, and what will happen, you do the opposite. You never will get a closure, you get even more a claw position. And here you can see it. If you put there a pressure by having a tape, then you can excite the motor neurons in it and the muscle spindles, and they will react in a nice, proper way. They say, okay, I have some pressure on my muscle belly. Okay, I start to be active and open again. So this should not be applied, especially in the last scenario. Good. And so we have developed a workflow just to how to combine surgical and therapeutical procedures. You can combine nicely both, but if a person does not want to use surgical procedures, of course you can only concentrate on classical treatment strategies, but use them properly. You do functional task-oriented training by using electrical stimulation at the same time. That's beautiful to do. You can play cards with stimulation system. You can comb your hair. You can play piano. You can, whatever you do, you only need to program your stimulators for proper movement. And it's really nice, doable. And then you can have a look if you need tendon transfers. You can do the same and think of nerve transfers. Of course, you looked at all kind of stimulation parameters are properly and correctly applied. That means that you identify lower motor neuron lesions and apply the correct form of stimulation on it. And you have a good structural training. Then you can also do direct muscle stimulation with functional tasks. It's also possible. And yes, if you know it, you do it with the lower limbs. That's perfect. I do it with the upper limbs. It's also doable in function. And so you combine everything with everything that you have it. Okay, on the technology part, what can we use? I think in upper motor neuron lesions, array electrodes are really good. And I have no personal interests in these electrodes or in the fascia system, but I think for the upper limbs, that's a quite good system that you can create perfect movements. Yeah, you need a little time the first time. And yes, there are some technical issues if the forearm is a little bit too small for the existing electrode sizes. But then you talk with the people that they create smaller electrodes. Also, they have to learn that. We have to work with engineers together, the clinicians, to tell them what are our needs or the need in the practice. So that works quite fine. And you can do also a simple training with patients that they should at least perform this movement that was not doable before. And what did we do? We put a weight in the hand and stimulated the pronator teres muscle very concretely and trained it with weight. It was a simple power training of one selective muscle that was recommended, and we did it. And after a while, the patient, after 2 weeks, the patient could perform it without stimulation. So it's easily done. Also, direct muscle stimulation can be done. If you put this claw pinch there and do the stimulation by pressing it, and you see it slightly on the video. Or sometimes you have also, yes, that's true, you have to hold the electrodes. And because if you wrap electrodes in a denervated tiny muscle, then you give so many pressure on it that you have directly a spillover to other muscles. So then you have to hold the electrode. Yeah, that's boring, but whatever. We are not there to be satisfied with ourselves. The patients should be satisfied afterwards. And you can combine it with movements. If you use a TheraBand, rubber band, and the patient is training here the ECU muscle with direct muscle stimulation. And here we have also included a thumb muscle in the system, and he's performing the movement. It can be nicely done. And you know, denervation is critical. Yes, the denervation process, it's written in the literature that normally you have this acute to subacute phase up to 2 years. And after 2 years, you have a really denervation sign in a muscle. But I can tell you from clinical practice, especially in the upper limbs, that gets a little faster, this denervation, that you find connective tissue and fat really fast into an upper limb muscle. So therefore, early stimulation is recommended if you want not to start at a phase where it's needed to stimulate 1 to 2 years to reconstruct or reverse a muscle into contractile muscle tissue. It is possible, but it takes some time and you don't want it. So we know what's going on in a denervated muscle. I don't want to focus a lot on it, but it's interesting to see how long it takes if denervation signs are visible. So we start with, give you an example, we start with stimulating the delta muscles in high tetraplegics on intensive care to avoid the subluxation of the shoulder girdle. And we see in the acute ones, 2 days after injury, that you can easily stimulate in C4 tetraplegics the delta via nerve. And C4 is a segmental innervation for delta muscle. So you expect a denervation. And if you go on stimulating them on the intensive care, you see in the literature it's described up to 8 to 10 days that you can stimulate a damaged lower motor neuron via nerve, and you see a reaction. I can tell you from the delta muscles, it takes about 3 weeks, and then the excitability of the delta in a C4 that has a lower motor neuron lesion on the delta is gone. And you can immediately switch to direct muscle stimulation. And you should do so. And not saying, okay, the muscle is not even, can't be stimulated, we stop it. That would be the worst case to do. I recommend to continue, especially in those who are re-innervating or having an intact reflex arc on this level. That's fine. They are not so the ones who develop pain in the shoulder. That are the denervated ones. Okay, and it was shown in the group of Helmut Kern by the RISE project what happens in the lower limb muscles. And we were curious in our center, what happens with the upper limb muscles? Do they behave in the same way? And we set up a study in one intrinsic and one extrinsic forearm muscles, and we wanted to see if this muscle in a chronic stage and in an acute stage, how does this muscle behave in terms of muscle thickness and the pennation angle that is a surrogate of thickness and of muscle morphology. And so we did, and we could see that by starting stimulation in a denervated muscle that we could increase significantly the muscle thickness in both muscles, in the first interosseous muscles and in the extensor carpi ulnaris muscle. We could increase muscle thickness, and we could even increase the pennation angle of the muscles. And we had some cases there were no pennation angle visible anymore, and after 12 weeks in those tiny muscles we could regain a pennation angle. We saw one. And I think that was for us quite amazing, and that motivated us to go on with direct muscle stimulation in the upper limbs, in tetraplegics. And even more, if we look, we did a correlation between the beginning of the stimulation and the muscle thickness, and we looked if there's a correlation after 12 weeks that we can estimate by knowing the muscle thickness by beginning of stimulation, what we could expect after 12 weeks, and that is a significant correlation. So you can somehow estimate by looking to the time of lesion and looking to the muscle thickness in beginning of the stimulation, what you can expect after 12 weeks of stimulation, and that you and what you can't expect. And that gives an information to a patient, and you can also talk with the patient if it's worth to go on. And you know also, can you recommend later a nerve transfer or better not? So you get a lot of information for a future procedure. Okay, that's so far so good. That's all from my side about these 3 aspects of electrical stimulation to use in the upper limbs. I want to thank you for your attention. I thank, of course, my team. Without this team, it would not be possible to work like we do. And a little bit, no, it's not visible on it. It's a stick. I want to a little bit an advertisement. We have a course in November, and we have some flyers. And this time we are dedicating about breathing, phrenic nerve stimulation. We do a lot of other things about swallowing and mimics. So you can find it online, and it's not only in person. You can come. You're warmly invited to come to the Swiss Paraplegic Center, but it's also possible to participate online. It's a hybrid course. 2 days, 18 and 19 of November. Okay, that's all. Thanks.
Thank you very much for the presentation. And the flyers are also outside if someone is interested.
afternoon it's very particular. I can hear you. Yeah. Okay. Yeah, yeah. Why I have here too. No, so we did a standard deviation of where this motor points is exactly the size of the pen electrodes. It's 0.5 centimeter, so half centimeter. So yes, now it's easy, but to find those, to identify, it took hours, and friends that gave me the arm and pain of those friends. No, that was not easy to find, but it is easy to apply now. You have to be aware of some aspects. So it should be in a seated position of the patient, and the angle of your elbow should be in between 90 and 80 degrees of flexion here. If you stand the elbow, then it does not work. Then you don't find with this measurement. If you put the right position and draw this line, yes, and I have a complete table with different forearm lengths, with all the deviations where you can find them. They are not all on the line as you saw. You have to go from the line a little bit radial, and you have to do it in the right angle and not taking a little bit round. So yes, there you have to be careful. It needs some training, but at least if you are trained, it seems to me to be easy for me. And my colleagues also, and we use it as a standard assessment now in the center, they do it. They only claim that they can't do it in a lying position. But that was never thought to be for a lying position, because it should be used before nerve transfers. Mm-hmm.
Is there a difference when you're measuring healthy and spinal cord injury and maybe in stroke?
No, it's no difference. No, you can do it in stroke patients, you can do it in spinal cords. Of course, in... No. No, we tested it in about... you have seen how many, and we do also testing in the ambulance service. When I have stroke patients, we can rely on these motor points. I first thought by the innovation... No. Yes, you can use it also after years. Yeah. I thought they would slide to the right or to the left, but the point, the line remains the same. Sometimes it's tricky in between the APL and EPL muscle, because they are so close to each other. There you have a little bit sometimes to move, but for the others it works quite fine. Mm-hmm.
Okay. Any more questions? Oh, it works. Okay, thank you very much. One more applause.
You can. Okay.
I can stop.
You do
Fine.
it.
Thank you very much.
You're welcome.
Can you... our next speaker is Dr. Sebastian Mateo. Well, he's a assistant associate professor at the Claude Bernard Lyon University, and
faut
small question?
Sure.
Is it Cécile Pacore? Pacore?
Pacore.
Pacore? Pacore?
Yeah.
Okay. That R is a problem for me. Yes. Just when they
it's
finish, we can try.
You will.
Because if it's working, I don't want to let her.
No, it's Windows is fine. Mac is
Okay.
a bit. That's why.
But I don't have.
Like those kinds of things. Other way around.
imaginé qu'il y avait un. Tu sais qu'on peut sortir de l'extérieur.
Ah ouais. Non, mais vu qu'il y avait rien, en fait, je voyais à travers, je me suis dit que c'était figuré, quoi. Et on...
Ah si, mais on aurait pu avoir un truc.
Ah, ouais. Ah oui,
pour les
ouais.
flèches, tu vois.
Je pense pas qu'ils aient mis ça parce que c'est vrai que si on doit accéder à la salle. Bon, bah voilà. Merci.
one you want.
Okay.
You're the boss.
1 minute. I will say like 2 words about you and also introduce you and then
Sure.
begin.
Okay, you can try.
Feel free. You're going to talk about autonomy, right? Okay, so I'll just mention it and you can speak about it.
Whatever
Okay.
you feel like.
Okay. I'll just. You're late. Okay, we are continuing. Hopefully. So our speaker is Cécile Pacoret, sorry, from Autonomy in Lyon. She's an engineer and she's also into robotics, right? And she's working on, working with therapists to bring the know-how from, the needs from the field and from the therapy to the lab where we actually need to develop those solutions for those needs. And she started an NGO here in Lyon last year, about which she is going to talk about. So please.
Thank you, Peter. So hello, I'm Cécile Pacoret. I'm from the Human Lab Autonomy. I work in robotics in Sorbonne University, Carnegie Mellon University in US, Neuroscience Department in University of Geneva, but I'm not gonna talk about data. I'm gonna talk about story. I'm gonna take a little bit the focus away and tell you stories about people that are behind your graph, behind your statistics. And I hope, like it's the end of the day, it will be a little bit lighter, but also deep and engaging, I guess. So this is a story about Hélène. Hélène have a multiple sclerosis since she's 25, and her therapist told her she have to walk with a cane. And at 25, can you imagine to be proposed to walk with a cane? That was very difficult, and she refused to walk with it till she fell, carrying her baby in her arm on the floor. This is also the story of Youssef. Youssef got a stroke at 16-year-old, and he's now hemiplegic, meaning that he has only one valid hand. And one of his most enjoyable moments was playing PlayStation with his family on Sunday with his 11 cousins and brothers and sisters. And he cannot do it anymore, as he cannot use the two joysticks. I want also to talk about the story of Geoffrey. Geoffrey has been hospitalized several times for psychic disorder. He survives because he's an artist, and he lost faith in doing something more with his art. So, getting a little step further in the story of Hélène, she told me that one day she found a book for children, and where the daughter and the classmate paint the cane of the mother and give it to her as a present for her birthday. And she cried when she was reading it to her children. And she said, like, I'm a former engineer, and I can teach myself 3D design and 3D printing, maybe I can do something for like getting this object to be more familiar to me. And when she's at home and her husband, her children go to work and school, it's very hard for her to start by herself. In the case of Youssef, PlayStation, you need 2 hands and good motricity to play it. It's not ideal for many situations when you are amputee, you have hemiplegia, you have a temporal immobilization after an accident, or even if you want to drink beer or smoke a cigarette while playing video games. So he say there is something that could be maybe in the market. So he looked online, he looked to marketplace, he met companies, startups, he tried devices, but there is nothing he feel like he can play with. And he doesn't want just a compensation of handicap. He wants something good enough. He wants something where he have a fair chance to win the game. And he tried with plasticine to make some shapes, and he got many ideas in his head, and he feels that he have something new that doesn't exist yet, but he have no technical qualification. He have not even the A level. So how can he do it by himself? So Geoffrey, some context, different situation. At 40, he wrote so many texts, but he didn't achieve much in his life. Basically, he stayed at home most of the time. And his texts are acclaimed by the public, and many people tell him he deserves a professional recording, but he has no money. And he cannot do it without money, can he? Or, like, this is his portfolio as an artist. How can he not have a CD and show what he wants to do and maybe go to concerts? Or he have no knowledge about informatics whatsoever. He cannot do emails. He cannot do a poster. He cannot burn a CD himself. So he is so in difficulty with self-confidence that he cannot even ask his friends for help, and he's very afraid to face refusal and disinterest and obstacles. So this is a typical story that we hear in human labs. This is our NGOs and networks of thought places that propose to prototype together any disability aids or multimedia or artistic projects that disabled people might have and want to be able to do. And this could be inside fab labs, so laboratory of fabrication that are also open place, or outside fab labs. There is a maker space, but also a place where we listen, we learn, and we fabricate and play together with this bright imagination that they have and their insights as they are real expert users. So we are not only solving technical problems, we are also solving emotional problems, emotional needs. Fast prototyping cannot solve everything, like 3D printer, laser cutter, thermoforming, or other artisanal techniques, but they give multiple choices of form, colors, texture, and an infinite possibility of personalization and incremental design. And maybe you're familiar with technical aids, but they are most of the time tasteless, poorly fashionable, made to be invisible, out of sight, in poor attempt of reducing the stigmatization. But if you look to this full detection of Magali, it's not like it's full of stigmatization there. It's not very beautiful. Everybody know what it is, and they're perceived ugly, unfit, unbalanced, and what they receive for an answer is like, get used to it. That's the only things we have. And the person have to adapt to the technology and to society all the time. when they are in disability situations. So, like single prototyping is like compared to is to mass production of medical device what single-scale study is to test statistical psychology. We can, with single prototyping, grasp the full complexity of an individual, of his life, of his realities that will make it a psychosocial, economical, technical problem, and not just a technical problem as it's most of the time look at. And like we ask the question, why do the patient refuse aids or refuse treatment or like delay dangerously their use? It's maybe like taking them into account better in their complexity of lives that is around them that will help them to accept these aids. I remember a story about a researcher that told me once that there have been billions spent in like fully autonomous smart wheelchair, like fully equipped with sensor, like the next plus ultra is robust to any perturbations, obstacles, it drives you anywhere you want by vocal commands. But in fact, there is no users that want that. Like the people that have disabilities, they want the maximum autonomy they can get in their situation. So they don't want to be fully brought somewhere and have no like they are totally passive in the chair. They want something that will bring them to more autonomy. And he worked on the design of just a control handle of an electric chair that is a bit smarter than the other, and that's get to market when this chair, like nobody can afford it anyway. So you can notice that there is no patient in this wheelchair. I don't know why, but I think when the technology is there, there is someone using it in the pictures, and when we show them in our research, there is an hand inside our device, there is something that, and the patient also gives their pictures and is proud of the development he's doing with you. So I've been working here with the NGO ANS, and it was very natural to work together. For example, we work on heat management on wheelchairs, and like billions have been spent in very smart wheelchair, but there is no good like heat management on wheelchairs. Nothing that is like well, like eating well or waterproof or beautiful. Like the offer is very limited. Even more like life saving is like the eating of the hand when you have you're manipulating the joystick of your electrical chair. They are suffering like tremendous problem with heat when they are outside and or like doing handisport with their wheelchairs. There is no eating joystick, and it's a very small, simple design. We are going to technical high school to do the prototypes, and this is a teaching moments for everyone, for the user expert, for the students, and here you have one of the member of ANS that is working on the specification with the students. So it's all a process of prototyping where we are entering like an adventure. So talking a little bit more about this network, we are getting mature. We have like several places in France already where we can work on these projects, many partnerships with labs, companies, therapeutic centers. There is 3 labs in Africa, and there is 2 more projects starting in La Réunion and Perpignan. So this is a way to access high-quality user experts, and An ex-colleague told me last week, like he was having, starting to have very big troubles to access user of even non-invasive technology. Like the ethic committees start to be complicated, the university doesn't want to jump on that subject, so he doesn't know how he can like test his device. And he, in order to like train for Cibathlon, he hired the patient that is helping the development of the prototype and training for the competitions. So, for just taking the first human lab, which is in Rennes, started in 2014. They have like 26 new projects per year. They have like 83 contributors. They have like hundreds of moments of collective intelligence. This looks like kind of the perfect lab where we can like do some engineering research, and this is open place for collaboration with universities. Just to give you other numbers, we start our initiative in Lyon 1 year ago, and we are already overcrowded with projects and ideas and initiatives. Like students that have joined the programs are close to 200, and this means that there is a need, there is a want to participate, to contribute, and also show what's the creativity of the field look like. But what is the business model of single prototyping? Will we go to market with that? And if nobody have done it before, like, it probably means there is no business with what we are doing and what we are inventing. But actually, we are happy that there is no business. It's because there is no business in like small, like samples of needs, that there are so many to invent, and we need to have the expertise of their daily life to know what is there to invent and what is there to do. But prototyping is not the value proposition here. It's a pretext, maybe for a bigger picture. So I present you Nicolas Hichet, which is one of the co-founder of the first human lab in Rennes, My Human Kit. And he's saying that working on my own prosthesis, it changed my vision of my disability. I stopped to wish to change other people's perception. I focus now on changing my own perception. I am an expert. I exist. I have a place in this society. People ask me my opinion, and this is very important. I pass from a disabled status to where I need help to I have desire. I can do differently. I can act. So our treasure is not prototyping some like big invention, big innovation. No, our treasure is like empowerment. Like individuals enter through a process and transform themselves. I have more confidence. I have more self-esteem. I know how I can fix my own objective. My creativity and my singular vision is authorized and recognized. I acquire knowledge and know-how. I am aware that I have skills. I know how to use them and mobilize them, and I know how to transfer them to other situations. That's the whole path of the therapeutic process. And they also can shape the new specification for any medical device. They want a price. They can say what is a fair price, how it is customizable. Like they want it to be easy to repair because they have troubles to like find parts or reparation centers. They are proposing something different. So after this year, Hélène, she had been case study for a school of design, for a department of plasturgy, for an insertion program. She sold her first user expertise. She and her team won the first prize on a medical hackathon this year. And they make a new prototype, an elevator pitch. And she dreamed about a marketplace and community to talk about the cane and walking assistant and how to make ourselves, how to care about ourselves and our self-image. And she thinks that the can be the new sexy. I brought you one of her new prototype. You can try it. So Youssef, a few months ago, we give him what he qualified one of the most impressive experience of his whole life. He got a 3-day hackathon dedicated to his own ID, and 30 students from design school and numerical school worked within. 30 professors, therapists, experts, volunteers were also there around to not wanting to go home after midnight. They prototyped so a new cover for his ID, electronics, a game, a video games to do a demonstration. He said it was a really wonderful experience to catalyze so many energy around him, around a singular vision of what inclusive game should be, like in a real co-construction manner with the end user. And the visibility of this event makes that I couldn't find any design online before, and now it's multiplied by 10, by 100 every day. People that didn't publish what they were doing at home or adapting at home, now they put it online because they saw our event. So you want also the end story of the never-ending story of Geoffrey. So Geoffrey, with just few questions, it's making start again all the mechanic of how big an impact he can do with his writing and how he can give to his peers capacity to transform the troubles to making some art, making something about themselves in a more beautiful way. And by writing, he gets involved in an experimental project with Psychic Disorder Center, where he writes, he do writing workshop with, so you see here participants, and also open mics moments with them to go to a collective recording all together. And his students also, he can bring them to go to more confidence and more self-esteem. He know where they have been, and he know where he is. He can give them something of himself, of his techniques, to get better. So he came from staying at home to start his own professional project, what he always dreamed to do, his own workshop of artistic writing. So we see there like 3 stories of individuals that do not just transform themselves, but they transform also their peer. They change any contributor in their projects, could be students, therapists, researchers, fellow valid workers, institution, and also myself. Like, I work on project in robotic and neuroscience. I've been maybe flirting with science fiction a lot of time, working 10 years as a geek, doing some maybe like advanced algorithm, dating MATLAB, the software MATLAB more than human beings, are like products that I've developed. Maybe we'll never see the market. Maybe they will never see a user or a result. And I have skills that didn't have a real meaning or real sense before I meet those amazing and generous persons. And me too, I'm part of the experiment. I cannot say that I'm like a cold scientific, that I can remove myself from the protocol. No, my regard change, there is an intervention in this process. And like I invite you to join this process with me and like observe the way that creativity make move, make change, and can also influence other therapeutic processes that are going on for rehabilitation. And they are teaching me every day something, inspiring me new design, new ideas, new drawings for them. And they show also me strengths by their stories and wish to fight and believe every new days and transform myself. So I'm offering them and choosing open science and open source and open hardware development for it to benefit to a broader attendance. So if you use a proverb like alone we go faster, but together we go further, maybe we can like remove a little bit our white coat and the solitude of some dehumanized protocols and join for a moment some human labs and go to the playground and have natural sharing with our patients. We are co-workers and try co-construction as maybe a slow science, but like it takes time to build a really desirable future where we want to live all together. So thank you. You're welcome for any questions.
Questions?
Yeah, thank you for the lecture, and it's very interesting to see how you work with different types of users, and this is actually what I wanted to ask you. So how do the people with disability find you, and what type of users do you see? I mean, do you have most of them that are with some neuromotor problems or psychiatric issues, or what's the composition of the people?
So it's like we do basic communication, just being on social network. I mean, we have done very little communication and we have already so many people contacting us. We have all kinds of disabilities. Like I wanted to involve, for example, auditory disabilities. I proposed to my students in engineering school, like, let's do something about that, and let's contact and other NGOs and see what they think and what they need, and then they became involved in also being user expert, and they came to the showroom at the end of the semester to discuss and question the students. So it's just knocking doors.
Thank you very much. I have just a couple of curiosity. How long is the process from the first contact to the realization of the project? And then a second question is actually everything based on voluntary work? So you mentioned many students or just so you mentioned sometimes the business model, but so how do you manage that?
So there is different business model, like social business models around our NGOs. Some are like really linked to medical centers, and they have like workers from the medical center that are helping the voluntary based contributions. In My Human Kids, they have 7 full-time salaries, employees, and I'm about to be 3 full-time employees in my NGO, like next month. So it's good to have a core of people that can do all the link and capitalization of the project, that can do the administration and communication. But the rest, like development of projects, I have so many people that want to give a little bit of their time. They are there 1 month, 3 months, 1 year, the whole life of the NGO. And the process is, it could be very slow. For some persons, they are afraid to talk about what they really wish. They have an idea, but they just come to observe for a moment. And when they feel confident enough, maybe they talk about it. I'm also opening doors, like this is this program with a design school where I need 10 projects. And you have like a team of students where you can work with. Do you have a project? And then they say, oh yeah, let's do it. And like the working with students or volunteer for companies, it triggers something that they are not alone, and they're people expecting to work with the person, and so they start to do something. And we have no expectation of results, and we have results. So it's just being confident that they will go somewhere.
One more question? Yes.
Thank you. Thank you for your talk. My guess is more about outpatients and inpatients, and could be interesting if you can clarify this point. I am not sure that I see the deduction inside the hospital with a 3D printing in Henri Gabriel, but it could be interesting to come to see inpatients too.
So you mean in hospitals? So we are discussing with Henri Gabriel, and there is a parallel network as human labs, which are called rehab labs. And this is like a department inside a medical center, where human lab are outside the medical center, so they can work with people from the city, and it's like welcome to everyone. In medical center, it's more also a relationship of doctors to patients, but they have this wish to do some open source development, to bring some skills to their patients, so they're able to discuss technically together about the medical device. So in Henri Gabriel, they have the wish to do a project of rehab lab, and so we are testing together if the patient wants that, and by bringing some 3D printers there, like I couldn't do the workshop properly because they were everywhere, asking too many questions. Like therapists also came and wanted to have some explanation, to touch a prototype, see some videos. So yeah, there is a very big wish and motivation there.
Okay, thank you very much.
Thank you.
And our last speaker for today is more exercise.
Thank you very much. Thank you for still being here. So it's kind of late and tired, but I will try to. Today I'm going to speak a little bit about hybrid FES exoskeletons, so which are the potentialities and the main challenges in this field. As we all know, so I can go fast, but there is a strong need of developing methods to improve motor recovery after neurological disease, and mainly speaking about stroke, there is the need for recovering both walking ability which is actually the main goal of stroke rehabilitation, but also upper arm mobility should be recovered after a stroke disease. And we have learned in the last 20 years several methods to drive neuroplasticity in order to improve motor recovery and motor relearning. And so basically here I like to have these slides in which I summarized what I have learned in the last years and which are the main elements which help to improve neuroplasticity. So to augment proprioception is for sure one mechanism, and we all know about the use of FES in this sense. Also the possibility to involve the patient in interactive and engaging tasks, to let him volitionally participate into the training, having a personalized therapy, a repetitive therapy, so practice a lot, make the intervention very early, and having a functional and goal-oriented training. All these elements can be actually supported by the use of technology, and indeed the effort of the physiotherapist and can allow to perform therapy very early with a very high level of safety, and also give the possibility to assess motor performance during training. To FES, you are all familiar with that, and you are all familiar with the advantages and disadvantages of FES, which I summarized in these slides. So on one side, we can augment proprioception, and we can also induce active muscle contraction, so having central and peripheral benefits. But on the other side, we have problem in control and also the big issue of muscle fatigue. Just these slides, I want just to summarize which are the main clinical application of FES of the last 50, 70 years of research. But still, these problems are still there. On the other side, we have robotic devices. These can be categorized into two main types, hand effector robots and exoskeleton. Hand effector apply the mechanical forces at the distal segments, so are very easy to set up and control, but they do not control the proximal joints, so are less safe. While exoskeleton, you have robot axes aligned with the link of the subjects, so you can control directly each joint, but then they are more complex and expensive. Here we have just some examples of lower limb, hand effector, and exoskeleton, which are available on the market, from the lower limb and for the upper limb. And you see that mainly for the upper limb, we have both passive and active devices in both categories of robots. Rehabilitation robotics have the main advantage of being able to promote high intensity, high dosage, and personalized training. It can provide real-time monitoring, measuring a lot of information about the therapy, and can reduce, as I said, the effort of the therapist. But on the other side, the actual systems are still very bulky, difficult to wear. We had the problem, the so-called slacking effect, so having the patient being driven by the robot can be not so effective, and also sometimes we have problem in the workspace limitation. However, actually in the last, I would say, 30 years, there have been a lot of clinical studies involving lower limb and upper limb robotics, which at the end says that, so for the lower limb, that robotic gait training in combination with physiotherapy may improve the recovery of walking, not necessarily more than other type of therapies. So sometimes they can equal, but they are not really superior to standard therapy. And the same results also has been achieved from the upper limb. And in the upper limb, I have to say that the main clinical studies has been run with end effector devices, while exoskeletons are reached the market later, and so didn't have been tested extensively on patients. Anyway, what is very important to remember always is that robots do not replace the physiotherapists, but are tools that can help and is not rehabilitative per se. In the last 20 years, I would say 15 years, we have started to speak about hybrid FES robotic devices. In this case, we want to combine two different technologies, FES on one side and robotics device on the other side. And this definition has been given by Del Ama in 2013. So hybrid FES robotic systems are systems that rehabilitate or compensate motor function through the combined action of muscle activation with FES and electromechanical forces supported to joints. So we use both devices together. The combination can help to overcome the single drawbacks of each technologies. And so on one side, the robot can improve FES control. It can delay the onset of FES-induced muscle fatigue. And on the other side, the additional torque induced by FES can reduce motor power and weight, and so improve the wearability of the robots. Actually, in order to reach all these objectives, in order to really get the advantages of the combination, what is needed is a real cooperative control system between the motor and FES, while usually is just so far a superimposition of the two. So usually there is just a timing synchronization between the two devices, but no real shared control between the two. And so at the end, you cannot really achieve the big advantages of the combination. So I will just go fast into the literature and then propose a couple of examples that we are actually developing in our lab. So speaking about hybrid FES robotic system for gait recovery, in the literature you can find combination of FES with passive gait orthosis and powered wearable robots. Starting from the first, in this case is FES is the motor, so it's used to activate the muscles, while the robotic system is used mainly as an energy dissipation devices. These devices are typically made by joint brakes or elastic elements in order to reduce somehow muscle fatigue, for example, having brakes which locked the joint during stance phases, and so then you can switch off FES and then reduce muscle fatigue. Usually they are controlled with finite state machines. In this type of approach, you cannot really speak about a shared control between FES and the motor, since the job is done by FES alone. Speaking about instead power wearable robots, typical structure of power wearable robots, usually they apply power at the hip, they have some dissipating power at the knee, and then some storing and release energy at the ankle through elastic elements. Usually are made by DC motor gearbox combination with electric drivers. And typical control are like a feed-forward control of FES with predefined stimulation pattern, which is synchronized with the gait phases, while the motors are usually controlled with a position control following predefined joint trajectories. Also, in this sense, there is not a real shell control, as I said before, while I have to say that there are few examples of cooperative control systems which adapt to muscle fatigue, typically for 1 degree of freedom. And specifically in this type of approach, we have also made within a national project called FESLEG and funded by UNIL in Italy, we have the objective to design an hybrid FES system for gait training based on a cooperative control strategies. And basically, we are actually working in combining a twin exoskeleton, which is an exoskeleton developed by the Italian Institute of Technology. And this exoskeleton is made by one motor at the hip and one motor at the knee. And these are two Maxon motors with encoder to measure angular position. and then as a modular structure, and different sizes are available. And we are combining these motors with this motorized exoskeleton with two stimulators, the Reamove Free stimulator from Hasomed, 4 channels each. So basically we have 1 stimulator per each side of the leg in order to be able to stimulate up to 4 muscles per leg. And what we are actually doing is actually to include the Hasomed stimulator within the motor loop of the motor, within the control loop of the motor, in order really to build a shared control. This is the typical current control stimulator with the biphasic waveform that we are using. This work actually has been presented by a PhD of mine, Francesca Dell'Eva, who is not here at the last Rehab Week. And in particular, she was presenting at Rehab Week a comparative control at single degrees of freedom. So in this case, we were performing a kick test, so just knee extension, stimulating the quadriceps muscles and controlling the knee joint of the exoskeleton. And this is the cooperative control scheme that we built. In particular, you see that we have, for a motor control, instead of a position control, which was initially included in the exoskeleton, we modify it. So a position control basically provides a rigid tracking of a trajectory. So you cannot actually move from the trajectory that you want to follow. So even if you try to extend by arm, the motor is too strong and you cannot change the trajectory. We modified this position control into an impedance control that actually allow a more compliant trajectory tracking. So we are still tracking a trajectory, a desired trajectory, but with a more compliant behavior. And this allowed FES to add part of the job in the control. So as you see here, starting from a desired trajectory and velocity and acceleration, we have an inverse dynamic models that allowed us to estimate which is our desired torque that we want to provide to the motor. So this number that we compute here. Then the main block is this allocation factor alpha that you see here. Basically, what we are going to do with this factor, this is a number going from 0 to 100%, and if this number is set to 100%, we are asking the motor to do all the theoretical job. So we have estimated the feed-forward torque, and we give all this torque, desired torque, to the motor, and the motor provides this torque. Otherwise, we can decrease this factor, reducing the contribution of the motor, and then let FES act simultaneously. As you see, the motor actually has this feed-forward torque, but also has a closed loop, which is this impedance block that basically provides a feedback torque in order to, at the end, track the trajectory. In particular, I want just to mention that in this type of exoskeleton, we do not actually measure the torque. So we need to estimate the torque. This is an implicit impedance controller, so we do not have a real measure because these sensors were not included in the exoskeleton we are currently using. For what concerns the type of FES control that we are implementing, this is a sort of, so basically we are taking the feedback torque, so the correction given to the motor. So how much is the error that the motor needs to correct? And we use this error in order to update the stimulation parameters. So in particular, so of course we will have some calibration at the beginning, but if you see here, basically, if the error, so this tau FB, which is our torque feedback, is above a certain threshold, then we are increasing the stimulation. If it's below, we are decreasing. If we are in a certain range, we are keeping the same value of the iteration before, in a sort of iterative learning controller. So iteration by iteration. We are speaking about walking, so we can take advantage of this type of approach. And then we have a wafer generator that is, let's say, similar to the shape of the movements we want to produce. So what we have done so far, and actually what we are presenting here, is first test on 4 able-bodied subjects during this task from 90 degrees up to full extension with one stimulator just stimulating the quadriceps, as I said before. And in particular, we compared 5 modalities. So as a baseline, we have just the motor controlling the movement, so with no FES. This is our target root mean square error of the trajectory tracking, so our best condition. And then we were trying to reduce the contribution of the exoskeleton and see how FES could help. And here, I just try to summarize the results. So, of course, reducing the contribution of the exoskeleton, we can, not a force, but actually reducing the contribution in the feed forward of the exoskeleton, we could actually reduce the total torque provided by the motor. And then, of course, we increased the current provided to the muscles. But we could, up to this level, keep the same root mean square error in the tracking of the position, while here we saw a little bit of increase. And we actually explained this mainly because with able-bodied subjects, we were not really able to increase as much as we need the current, the maximal current, because of toleration, actually. Indeed, you see that basically already at this level, we reach the maximum value, and we do not have the possibility to increase anymore the stimulation. But I think that this first proof of concept show us that actually this combination could help the decrease of the motor torque required to the motor and actually preserving the same capability to track. So this is what we've done for the lower limb. Of course, what we still have to do in several steps in order to reach our final goal. So first of all, we are working in the optimization of the current waveform. We are working on a dynamic modulation of the motor assistance in order to really follow the onset of muscle fatigue. We need to extend, and actually we are working on extending this concept to a multi-joint control in order to perform it during gait. And we need to move to do tests with patients. Moving on the upper limb, also in these cases, we have seen that we have combination of FES with passive mechanical support and active robotic systems. Starting from the first, in the literature, you can find several passive mechanical supports, which usually provide arm weight relief. That is usually set at the beginning of the training session and then kept it constant. And usually the combination with FES is made using FES mainly for grasping and using arm and hand muscles. Open loop or closed loop approaches are usually implemented, but typically is a feed-forward pattern of stimulation that is applied, and that can be triggered by several mechanisms, which could be EMG, BCI, eye tracking. We could not really speak about a real share control because the passive device just provide weight assistance, and FES usually support FES grasping. In this sense, we have run a European project which ended a couple of years ago, that is the Retrainer project, in which we developed a 4 degrees of freedom passive exoskeleton, in which we supported elbow flexion, shoulder elevation, shoulder rotation, and trunk inclination, so the patient has the possibility to move the trunk forward. And we integrated in this, with this exoskeleton functional electrical stimulation up to 5 muscles, so of the upper limb, so biceps, triceps, and deltoids. And this stimulation was EMG triggered based on the volitional residual activity of the patient. We also developed a graphical user interface in order to set the therapy. And mainly, if you see here the smile, we were measuring EMG while FES was on in order to provide a feedback. And the smile was happy if the patient was still contributing into the task. Otherwise, if then the patient, after trigger FES, was stopping doing the job, then you had a negative, like a sad smile. In order to trigger the different, so we had several exercises like hand to mouth, for example, and in order to trigger the reaching of the target and then the reaching of the mouth and so on, we were using interactive objects with RFID readers. So when the antenna, which was mounted on on the wrist basically was approaching the target, then the exercise proceed automatically. And we have used this system in a randomized control trial involving stroke patients up to 9 months. So in which the first stroke event was 2 weeks up to 9 months before enrollment, with a little of capability to move arm and shoulder muscles, so muscle research council above 1, in order to let them trigger FES and participate into the exercises, low spasticity, and a good collaboration level. We recruited 68 stroke patients, which were randomized into 2 groups, the experimental group, who perform 30 minutes of training with retrainer and 60 minutes with advanced conventional therapy, we call it in that way. And then the control group was performing 90 minutes of advanced conventional therapy. The therapy was kind of long, so we perform 3 sessions per week for 9 weeks, so 27 sessions in total. And for advanced conventional therapy, we meant that the patients were performing upper limb, passive and active motion, arm, cycloergometer with FES, mirror therapy, repetitive task training, virtual reality game. Nothing involving robotics were in there, not to confound it. This is our sample. So we recruited, so the mean age was above 60 years old, a little bit younger in the experimental group. And the time to stroke was about 2 months in the mean values. And we have both ischemic and hemorrhagic stroke, more ischemic as normal actually, and the affected size was basically half and half. So I'm just reporting here the results of the primary outcome, which in our case was the action research arm test, in order to evaluate the arm functions. And basically here, what we notice is that both groups actually improved over time, but we got a significant time by group interaction factor, indicating that the experimental group improved more than the control group. And so what we actually concluded is that training with retrainer was superior to advanced conventional therapy in improving arm function and dexterity. But actually, I'm not reporting the other outcomes, but when we moved to real-life scenarios, so to activities of daily living, we still have a limitation in transferring the capability to reach actually the daily life activities. So we did not really get an improvement in daily life activities outcomes. Moving with the combination with active robotic systems. In this case, there are some examples again in the literature, and usually again, FES is mainly used for grasping and hand opening, while the robotic device is used to move the arm in the 3D or 2D workspace. Sometimes FES and robot act on the same joints, but usually never there is a shared control. I have to say that there is just one example of a shared control recently presented in Rehab Week by another group of us. And and then also we presented at that time an example that was the one that Federica was introducing this morning. So I don't want to repeat actually, but also in these cases we were trying to design an hybrid FES robotic system to support elbow flexion. This was done with a test bench that is shown in this case. The main difference with the setup of before is that here we have a torsional load cell to measure torque, the interaction torque. So we can be very much more precise in the motor control and also overall in the cooperative control strategy. And this is the control scheme, but I would say that is similar to the one I proposed you before, so I don't go into the detail. It's the same concept. So there is the allocation factor that share what we ask to the motor and what we ask to FES, and we have this iterative learning control that adapts the FES parameters based on the trajectory tracking error. I think that I spent a couple of minutes just to explain a little bit more the results, which I think are very interesting so far. So we have tested it with 12 healthy subjects, and we basically ran 2 different experiments. One experiment we want to compare different allocation conditions. So as before, we were decreasing. So we were having an FES only condition in which actually was performed again inside the test bench. The motor was activated in order to be transparent, so in order not to, so the patient shouldn't, the subject shouldn't feel the presence of the motor, but then we were not having an impedance correction, so no correction to the motor. And while the average condition, we were giving 100% of the allocated factor to FES, but let the motor correct with the impedance controller. And then we were decreasing the allocation factor to FES and increasing the motor up to doing FES 0. Here is the motor doing all of the job. Then we ran a second experiment in which we perform up to 100 elbow flexion movements with a payload in the hand, only with the modality in which all of the job was, sorry, actually this is an error here, all of the job was done by FES. So this is FES 100 modality. So what I'm going to show here is that basically comparing the FES only. So in this case is we just control the movements with FES and the motor is transparent, and we have a big position error which strongly decreases. So I want just to compare mainly condition 1 and condition 2. So the difference between condition 1 and condition 2 is just that in the condition 2, the motor is allowed to correct, and FES mainly do the job in feed forward. And you see that you get a big improvement of the position error, while you don't have such a big increase. Yes, there is a little bit of increase in the motor torque, but we are still keeping very low with respect to the condition in which the motor does the whole job, which is the green modality here. So basically, if we look at these graphs, with a small energy consumption increase between modality 1 and modality 2, we had a huge improvement in the performance, okay? So if you look here, we pass from 25 degrees median value up to 8, while here, we just increase a little the energy consumption. And we are actually also reducing a lot the charge, the stimulation charge. So this is actually half of the charge between modality 1 and modality 2. And this is very promising for experiment 2, in which actually we want to evaluate the fatigue. And here, as I said, we were doing 100 repetitions just in the condition in which FES was doing all of the job plus the motor correction. And if you see here, after the first 10 repetitions, in which the iterative learning control is reaching the optimal conditions, then you got an improvement of, so you keep the same root mean square error up to the 100 repetitions. So we do not experience a worsening of the performance. And also the torque that the motor is producing is not increasing. So this means that still the job is done by FES. Indeed, also you see that the charge is keeping to a constant value, and so the energy consumption is also constant. So basically what we notice is that after the first 10 repetitions, which are needed to reach our steady state, we can go up to 100 repetitions, keeping the same level of charge, keeping the same motor torque, and preserving the same motor performance. So we think that this experiment is very promising about the possibility really to combine FES with robotic devices, motorized robotic devices. I just want to conclude, last 2 slides. So I hope to have convinced you for the need for developing a shared and interactive control between robot and FES, and also including the volitional contribution of the patient inside the loop. So the control should adapt to muscle fatigue, should adapt to the progress of the patients over time, and should provide the minimal support to allow a correct execution of the movement. So should be following an assistance needed protocol. We hope that this can improve the wearability and minimize the encumbrance, possibly reducing the motor size and weights thanks to FES contribution. But of course, what we really need to work is an optimization of the calibration procedure, with sometimes a very, so now every time I speak with a physiotherapist, and now maybe someone can tell me, So if I'm using FES, but I need to calibrate it. I'm using a motor, I need time to place the subject in the motor, and now you want me to use both of them together. So we really need to find a way in order to do it in a very fast way. And this is also the reason why in our control scheme, we are not trying to do some mapping at the beginning. So we just start from some guessing parameters, and we want to learn from doing the exercises. What is very important mainly for the upper limb is the capability then to move to really ADL activities. So really transferring of functional improvement to ADL really need to interact with the real objects, real work, real workspace, and so on. Actually, what's next? What's next is that we really need to reach subject home. So we really need to have systems which are very easy to use, that are very easy to be set independently by the patient in order to really assure the continuum of care that we are all familiar with. What we are also working on, and I think that could be a very promising field, is the field of exosuits, and in particular, in my sense, the development of hybrid exosuits. Exosuits are very light, wearable, low cost, and I think that having the possibility to integrate FES in that kind of system could be also very promising. And then artificial intelligence could really help in calibration and detection of user intention. Then I want to thank you. I want to thank all the people of the lab that really support and run this work with me. And that's the end. That is a nice picture at the Rehab Week in which I was not there because I was sick, just the days of before. Anyway, thank you very much for your attention, for still being here. I hope that. Can hear you.
You were speaking about the time to set up the devices and how long does it take for you to be
Actually,
ready
for us,
use?
I have to say that we really try to have very, very fast calibration procedures. So what we are looking for, but of course we are so far testing one muscles, so then we are just looking for the minimal value of current that starts to, in which I start to see some muscle contraction, because that is like the minimal value. It doesn't make sense to go below that. And then like a maximal value of current that which could be the maximal correlated value with healthy subjects of the one that allow me to complete the movement. Then I just need these two, let's say, range, minimum and maximum. And then we start from some parameters in between. And that's why you see that you got an improvement of performance after the first 10 repetitions, because then is the iterative learning controller learning from the error of the previous repetition, adapting the parameters in order to find the optimal parameters, and keep to adapt the parameters if fatigue starts to occur. So then it's, I would say, 5 minutes calibration time for one muscles. So we are not really estimating the torque produced by FES. We do not have a model of the torque produced by FES.
And speaking about the maximum of the intensity, how do you deal the possible co-contraction that can occur? Because of the size of the muscle, you know, we have some, if you rise higher level of intensity, can have some co-contraction. How can you deal with this?
Working with healthy people, you can imagine that, of course, the stimulation level I need to complete the full range of motion for the biceps did not, I did not experience co-contraction with other muscles, but of course, this could be a big issue in our, so with the patient. I mean, with healthy subjects, placing the electrodes on the bicep of an healthy subject, the value of current I used did not elicit co-contraction because it's much, much easier. But of course, this could be a very big issue moving to patient.
One last question about the resolution. I understand that 5 degrees, the maximal resolution of error, then you can provide as feedback?
No, 5 degrees is the error we got. The encoder is very precise, so it's not a problem of resolution. The target error we got, average golf subjects and all repetition was about 5 degrees. But it's not, that was our performance, it's not the resolution of the sensor. I don't know if I'm clearing.
Yeah, but my question was not clear.
Okay,
but
sorry.
Can you bring to the feedback of higher precision than 5 degrees if you have, and I was not asking about the accuracy of your sensor.
Okay.
I was asking about the accuracy of the feedback provided by the system. Can it be better than 5 degrees? You have
the 5 degrees we got are mainly due to, I did not show you the trajectory trackings, but the 5 degrees we got are not due to the fact that we are not reaching our target point, so our full extension, but are mainly due because we are basically tracking the error during the repetition, and so we might be a little bit in delay with respect to the target with the actual movements. So that's why you got a little bit this 5 degrees error in average considering the word repetition. But the target error is lower. So at the end of the movements. I don't know if I've answered now to the questions, but thank you.
Okay, one more question.
So thank you for the very interesting presentation and devices that you are developing. So my question is, there is this parameter alpha, where you decide how much to allocate to motor and how much to allocate to FES. So the question is how to choose it. Maybe it's a more clinical thing, but still could be
it's
important.
not. So far we just compare different modalities using different value, but now we are working on a dynamic allocation. So the idea is that we would like to keep it the lowest and we would like to keep the motor contribution the lowest as possible. So starting from a low value of alpha, so allocating few to the motors. And so the idea is that we will start from that, but if then at some point the error increase, but we are reaching saturation level with stimulation, so we are somehow estimating fatigue in FES, we are going to increase this value. And maybe, possibly, we can recover and then also try to decrease. We are still testing, so we have a concept, we are trying to implementing it, but I think that in order to really develop a strategy, now we really need to move to patients, because with healthy subjects we tested the concept and that it could work, but then really to see how to really modulate, as you said, is more a clinical things that we really need to do test on patient now, which is going to be the next step.
One more.
Yeah, I have a question. Even on valid patient, did you measure also, does this, with the hybrid mode or without the hybrid mode, does it have an effect on tiredness or pleasantness to the subject? To do this exercise of rehabilitation, will it be more pleasant or more giving less tiring experience?
I mean, it should be more pleasant because you receive less value. At the end, you are receiving less stimulation, so lower level of stimulation, and actually also they should change less suddenly. So the feeling, at least for a healthy subject, is that it's more pleasant than using FES alone. But of course, because you have support also from another, so I would say that we expect that.
Okay, thank you very much.
You're welcome.